So what is basically a traction? Traction is that method which we use to immobilize the limb for a short period of time, right? For example, today you came across a patient in the casualty with the fracture of the femur, okay, let us say the neck of the femur. You cannot put a slab for the patient. So you need to plan for the surgery. I think you need to place the proximal femoral nails, but whatever it is, you need to plan for a surgery. For example, you have seen a patient of femoral neck fracture today, and after 1 week you are planning for a surgery, or let us say after 3 days you are planning for a surgery. Now before that, from today till the 3rd day, in this short period of time, you have to give a traction to the patient, and that is what is called as skin traction. Why do you give traction to the patient? So that bone fragments which are displaced, right, they don't displace more, to prevent furthermore displacement of the bone fragments. If the bone fragments displace furthermore, they're gonna rupture. For example, this is the bone, it is broken, right, it is displaced like this. If you're not providing a skin traction in the sense you're pulling the bone like this and putting it in a same alignment. So it is displaced now. If you're not giving a proper traction, what will happen is that the serrated margins, it can pierce or it can rupture an artery, it can cut the nerve or injure any nerve, right? So those are very serious complications that can lead to foot drop. So for that reason, you need to give a traction and then stabilize the fracture fragment, stabilize the leg, right? And you need to achieve the proper alignment of the leg and proper length of the leg. Okay, so this is what is called as traction. Traction is that method which you apply for the broken limb and immobilize it for a short period of time. Okay, why do we give a traction? As I told you, to immobilize the limb, to control the overshooting or to control the moving bony fragments. Third important thing is that to prevent muscle spasms, right? So whenever there is a fracture, the bony fragments, they overshoot, right? On the top you have got extensor muscles, in the lower limb. On the top you have got extensor muscles, bottom in the sense the back region, back you have got flexor muscles. So the extensors, they catch, they are holding the bone, right? These are called as the skeletal muscles. So they hold the bone and pull the bone. In the same way, the flexor muscles are also holding the bone and pulling the bone. So in that way, what is happening? The extensors and flexors are contracting. So that is what is called as muscle spasm, which will cause severe pain to the patient. So if the bone fragments are in a same alignment, right? If you are reducing the fracture and putting the bone fragments in a single line, what is happening? What is happening is the flexors, the extensors, they don't contract, they be in a neutral position and the spasm is reduced. Okay, so these are the things why we use a skin traction. Now, what are the different types of traction basically? We have got the skin traction and we have got the skeletal traction. Okay, within the skin traction, you have got two types. One is called as the fixed traction and another one is called as the sliding traction. What is fixed traction? Fixed traction is that, for example, I have got a fracture of my lower limb. Now, for example, this is the lower limb. There is a fracture of the lower limb. Now, what I do is that I put something down here and completely fix this bone to that thing, right? I put some material down. Okay, let us say I put a splint down. Okay, I put a splint. I hope all of you know what is splint. I put a splint beneath and I'll place my leg on the splint and completely I'll tie my leg to the splint. What I'm doing here, what I'm doing is I'm immobilizing, I'm fixing my leg to the splint, right? I'm completely fixing my leg to that splint. Now the splint and the leg, both of them are equal now because I've fixed my leg to the splint with the help of a bandage. Now what I'll do is that to that splint I will add weight. This is called as fixed traction. Fixed traction is, if you do fixed traction by applying force against a fixed point of the body. For example, Thomas splint. Okay, all of you know what is Thomas splint. Second thing is sliding traction. What is sliding traction is that in this sliding traction, you make the patient sleep on the bed, right? You make the patient sleep on the bed. Now, what you need to do is that, for example, this is the bed. This is the head of the patient and these are the legs, right? So for example, if I am the patient, this is my head and they are my legs there, over there, right? So I'm sleeping in a straight bed. I'm sleeping on a straight bed. So what you do is you just elevate the bed like this, so that my legs go on the top, my head is down here, right? So you elevate the bed, and when you elevate the bed, my legs are on the top, these hands are the legs are on the top, and my head is down. You put a pulley in between. Now you tie a knot, you tie a rope here all the way down and hang to a weight. So what is happening? You are in this direction and the weight is in the downward direction. It means your body and the weight, both of them are in the opposite direction. So this is what is called as sliding traction, where you are sliding down, right? For example, you look at a picture of Hamilton-Russell traction, you will very easily understand that. Okay. So what are the different types of skin traction we basically use? For example, whenever there is a fracture of the neck of the femur, right, or there is a fracture of the shaft of the femur. So all of you know what is the neck of the femur, and all of you know where is the shaft. Shaft is the mid part. So if there is a fracture of neck of the femur or shaft of the femur, obviously you apply a skin traction, and that skin traction is called as Buck's traction. Okay. So you apply a skin traction called as Buck's traction. As you can see in the picture here, you can see the fracture here, right? And at the same time, for this particular fracture, like femur fracture, femur neck fracture and femur shaft fracture, what type of traction you can use? That is Buck's traction. You can also look at the picture of Buck's traction here, right? How much weight you need to add? Not more than 4.5 kgs. You need to add 4.5 kgs, less than 4.5 kgs. The best is the 4 kgs through a pulley. The next one is whenever there is fracture of distal femur. So if this is my entire femur bone, right? Let us say this is my entire femur bone. Okay. This is the distal part. This is the proximal part. In the lower limb also, which is towards me, this is the proximal part, which is down there. That is the distal part. Distal part is making a joint, right? The knee joint. So that is the distal part of the femur. Whenever there is a distal femur fracture, mostly in children's, in that case you need to apply a specific traction. In this traction, you do two methods. One is Buck's method. All of you know what is Buck's method. I have shown you previously. Along with that Buck, you will also add a sling. So Buck's with sling, this is called as Hamilton-Russell traction. You can look at the fracture now. This is called as a distal femur fracture, and you can look at another picture of Hamilton-Russell traction. Coming on to the next fracture. In case of infants and in case of child, okay, whenever there is fracture of the femur in the shaft region, so in that case you need to put a specific traction known as Bryant's traction. As you can look at the picture of the femur shaft fracture here, and you can also look at the picture of the Bryant's traction. The next is that the clavicular fracture. Whenever you come across a clavicular fracture, obviously you put a skin traction. So what type of skin traction you put here? That is called as forearm skin traction. You can very easily look at the clavicular fracture over here in an X-ray, and at the same time you can also look at the forearm skin traction. Now in the femur part, you see two tuberosities. One is called as a greater tuberosity, another one is called as a lesser tuberosity. So whenever there is a fracture of the greater tuberosity, or second important thing is that this is the humerus. This is the proximal part of the humerus, this is the distal part of the humerus. So whenever there is fracture of the proximal part of the humerus, right, in these two cases, you put a specific traction, and that is called as a double skin traction. What is double skin traction? Double skin traction is patient will be sleeping like this. You have to abduct the arm at 30 degrees. See, this is the arm. This is the arm normally, right? This is the arm, for example, right? So you need to abduct the arm at 30 degrees, and what you need to do is you need to put the elbow at 90 degrees like this, right? So what I have done, so I have first abducted the arm in this way, and now raise the elbow to 90 degrees. Arm abduction at 30 degrees and elbow flexion at 90 degrees completely. The elbow has been flexed at 90 degrees. And now you need to add the skin traction and tie it on the top. So this is called as double skin traction. The next traction is whenever there is fracture of the humerus above the condyles, you call it as supracondylar fracture of the humerus. As you can see the fracture of the proximal humerus here, and you can also see the double skin traction, how it has been added. The arm has been abducted and then 90 degrees the elbow has been flexed, right? So this is the picture which you can see regarding the double skin traction. Now the next skin traction is whenever just above the condyle of the humerus, if there is a fracture, you call that as supracondylar fracture of the humerus. So whenever there is supracondylar fracture of the humerus, you apply a specific traction, and that is called as Dunlop's traction. You can see the picture, you can see the x-ray of the supracondylar fracture of the humerus, and you can also look at an x-ray of Dunlop's traction, right? Now these are the basic tractions which we use. Okay, now in what cases you have to use the traction, I told you. In what cases you shouldn't use the traction, I mean what are the contraindications? The first contraindication is going to be, for example, if there are any kind of abrasions, that time you cannot use a traction. If there are any kind of abrasions on the skin, if there are any kind of lacerations on the skin, so when the skin is lacerated, you cannot put a traction there, because that will widen the laceration, that will cause pain to the patient. If you see any kind of varicose veins, in that case also you could not put the traction. And finally, if the foot or if the limb is diabetic, right, and if there is a diabetic foot, if there is gangrene over there, if you're putting the traction, along with the traction the foot also is gone. So you cannot put a traction even in the sites where there is gangrene. Okay. Now I'll be showing you how to put a traction that is called as Buck's traction. So here you are seeing a case of femoral fracture, right? So what is exactly femoral fracture? As you can see, this is the femur bone, right? And in this femur bone, anatomically discussing that this is the head of the femur. This is the greater tuberosity, this is the greater trochanter, and this is called as the lesser trochanter. You can see this small part in between, this is called as the neck of the femur, where this patient had got a fracture of the neck of the femur, right? So when you look at the x-ray, it will be very obvious that you can very clearly see the neck of the femur fracture, but without looking at an x-ray, right? Just by looking, just by physical examination, or just by the position the patient has kept his leg, so based upon the position you need to tell that this is a femoral neck fracture. So this is a case of femur neck fracture, right? So whenever I tell you about femur neck fracture, what is that thing, I mean that location of the femur where the fracture has been happened? As you can see here, this is the femur bone. Now in this femur bone, you can appreciate two important things. This is called as the head of the femur, right? And these are called as the trochanters. So this one is called as a greater trochanter and this one is called as the lesser trochanter, okay? So, and next important thing is that between the head and between the greater trochanter, you can see this small piece of bone which is connecting the head with the both trochanters, right? So this is called as the femoral neck, right? So this is called as the neck of the femur. So this is the place where the patient had a fracture, right? Now, without even looking at an x-ray, obviously when you take an x-ray, right? X-ray, for example, hip with thigh, right? So when you take that x-ray, very clearly you can appreciate the fracture near the femoral neck. But without looking at an x-ray, the moment the patient is in the emergency department, by looking at the patient, you need to think that it is a femoral neck fracture. Now how do you do that? So physically, what do I find in a patient with femur neck fracture? So physically, what you can examine in the patient? You can see the patient's right leg, it is completely straight because there is no fracture here. Compare the right with the left leg where there was an femoral neck fracture. Now look at the left leg of the patient. What is the position? I mean, this is the position that is automatically achieved when the patient has a femoral neck fracture. Now look at the leg is slightly moved laterally. So this is called abduction of leg. And second thing is that look at the knee has been flexed. So there is abduction, there is flexion, and look at the foot here. The foot is it internally rotated or is it externally rotated? So look at the right leg, this is called internal rotation, whereas this is called as external rotation. So the patient's foot has been externally rotated. So overall, there is flexion, there is abduction, and there is external rotation of foot. So this is called as FABER. FABER. FABER stands for flexion, abduction as well as external rotation. So this is the classic presentation which you can see in a patient with femoral neck fracture. So what we need to do for this patient with a femoral neck fracture? For example, the patient came today to the casualty with the femoral neck fracture, and we are planning, after diagnosis, we are planning to do a surgery to operate on him after, let us say, 4 days. So in between that gap, so what we need to plan for this patient? Before we schedule him for the surgery, for example, let us say the patient came today to the casualty with this fracture. Finally, after the diagnosis, we planned to operate on the patient after 4 days. So in between that time, what we need to do for that patient? The thing which we need to do to relieve the patient's symptoms and relieve the patient's pain is called as traction. So basically guys, traction, whatever it might be, there are two types of traction basically. One is called as the skin traction and other one is called as the skeletal traction. Skin traction means you put a traction only to the skin and you hang some weight down. Skeletal traction is you put pin, you completely drill the pin or run the pin into the bone and then you hang the weights there. So that is called as skeletal traction. But in this case, what we will be doing is, we will be doing a skin traction to the patient. Right. So why should we do skin traction to the patient before we plan for the surgery? The reason is, skin traction is, first of all, skin traction is a conservative treatment that is basically done for a short period of time. Okay. So for example, look here, patient has got a fracture of the femur neck, right? All of you know what muscles are located on the anterior surface? They are extensor muscles. And what muscles are located on the posterior surface? They are flexor muscles, right? For example, this entire thing is a femur. Now all the muscles which are located here are on the anterior surface are called as extensors. All the muscles that are located beneath are called as flexors. So this is completely the femur. Let us say there is fracture of the femur. When there is fracture of the femur, what will happen is that on the top I have got extensor muscles which are attached to the bone. So these extensor muscles which are attached to the bone, they will pull the bone up like this. They will extend the bone up. They will extend one fragment of the bone up. Let us say this entire thing is the femur and this is the proximal fragment. This is the distal fragment. So the muscles which are attached here, they will pull the bone up, the proximal fragment up. And secondly, what can happen is that there are flexors beneath. So these flexors which are attached to the distal fragment, they pull the distal fragment down. So in this way, the bone fragments are completely displaced from each other. Actually, they have to be in a same length, they have to be in a proper length, aligned in this way. But rather, because of the fracture, the flexor muscles have taken its way, the extensor muscles have taken its way, so they are contracting separately. As a result, both the bone fragments, they displaced from each other. Now, when the bone fragments displace from each other, the extensor muscles are contracting too much. In the same way, the flexor muscles are contracting too much, and this is what is called as muscle spasm. I have to relieve the muscle spasm in the patient. If I don't relieve the muscle spasm, then the patient is going into too much of pain. Second important thing, as the bone fragments are completely displaced from each other, they can compress some nerves. Anteriorly, you have got femoral nerve. So this bone fragment can compress the femoral nerve. Posteriorly down, you have got sciatic nerve. So this bone fragment, as it is displaced posteriorly, it can compress the sciatic nerve. So I have to release those pressures if any nerve is compressed. So second point is, I have to release the pressures if any nerve is compressed. Third important thing is that the bone is not in a proper length now. There is no proper alignment. So I have to do traction in such a way that both the bones, they come and stick each other. Both the bones are like this. Now when I pull this bone and when I pull this bone, both of them come and they come into traction with each other. So this is the entire plan. This is the conservative treatment which I can do before I plan the patient for surgery, right? So what I need to do basically, all of you know, I have already told you that the patient's leg is flexed, laterally rotated, right, or externally rotated and abducted. So I need to properly align the patient's leg first. Okay. And regarding the pain management, I'm telling you the femoral fracture pains are so severe. So for that reason, you need to give intravenous opioids. Okay. Intravenous opioids are administered for the patient to relieve his pain. So the traction which I am applying on the patient is called as skin traction, not the skeletal traction. Okay. So what are the materials I need for this conservative treatment, which is called as skin traction? I need two important things. So one thing which you can see here, this is called as the traction bandage. So this is the bandage with which we can give the traction, right? So the two ends of this bandage are free, and next the end part of this bandage is tied with a rope. Okay, so this is called as a traction bandage. Next important thing is that this is called as a creep bandage. Once we apply the traction bandage, we are going to cover the traction bandage with a creep bandage. Now let us look at the procedure, how we are going to apply the traction bandage onto the skin and how we are going to apply this creep bandage and finally do the conservative treatment to the patient. So as I already told you, I have just now taken the traction bandage, right? So these are the two flaps of traction bandage. The middle part of the traction bandage is tied with a knot, right? So this is the complete rope that is tied to the middle part of the traction bandage where we are about to suspend the heavy weight. Okay. Now, how do I apply the skin traction to the patient in a patient with femoral neck fracture? So what is the first thing I do is that this hood region, whatever you see, this is the hardest part. This hood region, whatever you can see here, this is the hard part. So this hard part I am going to place on the patient's plantar surface. So this is how I am going to place it. And next here, one flap I am putting it on the left side of the patient, right? And another flap I am putting medially, one laterally and one medially. So now I will be taking the help of a worker, a healthcare worker or the patient's attender to hold it, to hold the flap still like this. Now, I'll be taking help of the next attender or the next healthcare worker to lift the patient by catching his fingers. Now, all of you know that here you have got the lateral malleolus, right? So you can see here, this is the medial malleolus of the patient and this is the lateral malleolus of the patient. So this is the lateral malleolus and here I see the medial malleolus. So whenever I am tying this creep bandage, I'll tie 1 centimeter, I'll start tying the creep bandage 1 centimeter from above the medial and the lateral malleolus. Now I'll ask the patient's attender to lift the leg of the patient. Now I start tying the bandage from the distal portion to the proximal portion. Now how do I start? 1 centimeter above the medial and the lateral malleolus, and now I start completely tying the bandage up. Now when you tie the bandage up, there is one small rule. What is that rule? Whenever you are tying the bandage, one rule you have to remember is that the second roll which you are doing should cover 50% of the first roll. For example, so look here, this is the first roll which I have already made. Now look at the second roll. The second roll is just covering 50%. You see, it is just covering 50%, not 100%. It is covering 50%. Next, the third roll is covering 50% of the second roll. Next, the fourth roll is covering 50% of the third roll. So in this way, you have to tie the creep bandage. Now till where you have to tie? You have to tie till here. I mean, this is the tibial tuberosity of the patient, right? So as you can see, this is the patella of the patient. Just below the patella, you have got the tibial tuberosity. Now look here. Let me show this to you again. This is the patella of the patient. Just below the patella, you have got the tibial tuberosity. So just below the tibial tuberosity, till below the tibial tuberosity, you have to tie the creep bandage, right? Now 50%, and now the remaining flaps, whatever you do is that you have to just rest it on the part which you have already tied it up in this way. And again going all the way down 50% again, 50% of the previous one, 50% of the previous one. So there is a red color dotted line which you can see here. This will help you to make the exact 50%. So finally, you need to put the pins here, right? So this is the procedure how you tie a skin traction. Now after tying the skin traction, what is the second thing which you do is that, as you can see, there is a rope here, right? So you need to suspend a weight to this rope. You need to suspend around 4 kgs, not more than 6.2 kgs, okay? Maximum to the maximum of 6.5 kgs. It is better to hang a weight of about 4 kgs, okay? So you need to hang a weight of about 4 kgs and then suspend the rope down like that. So this is the procedure of skin traction. Thank you for watching.